Thank you, Dr. Kavita. I request Dr. Meena to go ahead with her presentation on cerebral visual impairment. Dr. Meena Sike is a senior consultant at Little Flower Hospital, Angamali. She's a pediatric ophthalmologist and a very famous cataract surgeon, phaco surgeon. And he has many publications, has done many instruction courses. Over to you, Dr. Meena.
Thank you, madam. Good afternoon, all. I'll be speaking on cortical or cerebral visual impairment and how to deal with it. So first, what is cortical or cerebral visual impairment? It is a visual loss with a damage to the retrogeniculate pathway and usually with an absence of any ocular pathology. So the insult could be at the level of the cortex, or most commonly what we see when we send these children for neuroimaging, we get a periventricular leukomalacia, which is the most common finding that we see in a neuroimaging. So the significance of this condition is that usually you get a normal ocular examination, not always, and the associated neurological findings are very significant. And here the parents as well as the examining physician will be unable to comment on the visual status of these children. So a few theory on this visual acuity and their perception. Like we know that the occipital cortex is the main structure for our visual acuity, but you have a dorsal stream and a ventral stream, and this dorsal stream which goes into the posterior parietal lobe, that is mainly concerned with the mapping of visual images, whereby we can walk around normally in an environment, and the ventral stream which goes into the temporal lobe is mainly for the memory. So we need a coordination of these or all these centers for a proper visual perception. It's just not the visual acuity, you need a perception of the vision also to walk around in the environment. So all this has to work in coordination, which does not occur in these children. And there are a number of causes for CVI, and infants, the most common one being hypoxic ischemic encephalopathy, and you can get CVI even in adults following a CVA. Now coming to the systemic features, numerous systemic features, mostly neurological, are seen in them, along with other sensory problems like hearing problems are seen in them. So the common CVI, the common ocular symptoms in CVI are situations like this, like they can have something like a light gazing, they will just stare into the light, or they can have photophobia, which is more common, and blunted or avoiding social gaze, brief fixations and intermittent followings. All these are the features, and most of them will have neurological problem. So it will be very difficult for us to assess the vision. And poor visual acuity, as I mentioned, will be there, and it will be difficult to assess. And visual field loss, even though we find it difficult to assess, what we have seen is that the inferior altitudinal defects are very common. Usually they have a particular head posture. Probably it is due to their field loss. And first thing, usually they come to us with a neurological workup, but in case they don't come with it, you have to send them for a proper neurological workup and imaging and confirm your diagnosis. And in case detected, you have to work out a management strategy, which may not be the same in all. And you have to rewind and list out all the signs and symptoms and then decide on the treatment. And the first thing, before going to the patient, the criteria for the caregivers, they have to be patience and empathy is extremely important, and it's not just the ophthalmologist who have to manage this. You need occupational therapists, and it will be a coordination of many treatment strategies, and you have to treat or train according to symptoms and signs and set limits. And assessment of visual acuity in these children they can be assessed by Hoy et al.'s 6 different levels, of which level 1 is perception of light, that is the lowest level, and level 6 is almost normal sensory visual examination. So there are few terms that you have to be familiar with, and you have to unlearn a few things in treating or managing these children with CVI. Like mostly it is these agnosias. So what is object agnosia? There is a visual perception issue where they have difficulty in recognizing objects presented visually. Like if you show them a bicycle, they'll be able to see the handle, the wheels, etc., but they may not be able to perceive it as a bicycle. And optic ataxia, it is a visually guided movements are less accurate. Just like grasping a mug, they may not be able to grasp it properly. And this last one is very important, which is a simultagnosia, that is not to know a lot of things at a time. They can perceive only a fewer things. So here comes the unlearning part for us, especially for me, because whenever a child like this come to us, at least I had a habit of telling them, show them lots of colors and lots of things, but it's not so, because their speed of processing is very low. So they can't take too much to see and too much to grasp red signals for them. So this is the concept of putting them in a tent where they don't have too much to see and only a few things for them to concentrate on. And isolate the visual status. So this is a no for these children, that they have lots of stimuli for them that will be difficult for them. So try to treat them in a minimalist attitude, like in a minimalist environment where you have only a very few things, and avoid crowded areas. So this is the main reason they are very irritant when they come to a crowded OPDs. So obviously that is not the place to treat them. And they, just like in amblyopia, they are more receptive to single octotype. So show them single letters which are broader than their line of visual acuity, and treat them in familiar surroundings and background. And also they will be more attracted to high contrast. Like you can see this high contrast panda, and whenever you have to teach them on a particular thing, like show them, enlarge that feature, like enlarge the features of the toys, the eyes or the nose, etc., so that they can concentrate on that. And also they react better to moving objects than stationary ones, but you have to set the limits, because very high speed they may not be able to perceive. So you have to find a comfortable distance and speed of movement, and usually they have washed out colors. So you can do the color naming, like give an adjective to all the color, like you can say this is a black crow and a green leaf, so that they will relate it to that. And usually the lower visual field defects are very common, that I've mentioned earlier. So in such cases, you should be clearing the floors for them and holding their hands, and the reading stand where they can make use of the upper fields are more important. And stairs are another danger area where you can give them colors on the stairs, where reflectors, so that they know that they have to put up their legs onto the stairs, and colored markers on the doors. And because of the head posture, there are also vertically printed notes. According to the head posture, they can be given vertically printed notes for reading, and horizontal and vertical spacers and magnifiers, wraparound sunglasses for photophobia. So first of all, empathize with them, and first stay within their limits, and what our role will be, use maximum utilization of their seeing capacity with the help of other therapists. Thank you.